We will be recording this session. It is stored on our Canvas site. It also is a way on our website. Oh my word, that's not a good sign. I can't talk a lot today. We record it for educational purposes as well as for you guys to go back and review those if you want to. We've been on Zoom for a while, so we probably all know how to rename our profiles and raise our hand. But in case that you don't, if you'll take a minute to rename your profile, you can go either click the three dots or down at your by the participant and write what your name is and where you're from or your discipline. Really helps then as we're having those discussions or somebody shares something. It's a great way to just build that community of practice. If you would like to raise your hand, you can also raise your hand and we will call on you, or put your contact questions or comments in the chat, and Kurt helps monitor those for us. As we are talking at any time today or in future sessions, please remember to protect that individual privacy. So avoid using identifiable information like names, where they work, addresses. If you are unsure, please reach out to one of our hub members. We do have the asterisks in front of our names. We love the participation that ECHO provides. It helps us get to know our coworkers and our colleagues across the state. So that's where renaming and identifying each other is helpful, to be able to reach out to each other when we have future questions. We also have the ability to do case narrative or case presentation. So we have a really great one today from Caroline. I don't know why I want to call you Clora, but I do all the time. I apologize, Caroline Flora. But they are a great way to receive advice and situations and feedback from everybody that is participating in this session. So please remember to, if you have a case narrative, to send that in. The key components of an ECHO, if you've never joined one, is that we're really trying to build that community of practice, understanding who works in our field throughout the state. We have a didactic speaker, and then we do a case presentation with feedback. Case studies, again, are just a great way to hear from everybody about recommendations on a case that you are struggling with or that you just want more information about. So if you're interested in doing a case presentation, please reach out to Project Scope at usu.edu. Pre-registration always lets us know who to send that information to ahead of time. And so if we have upcoming sessions, so please consider to pre-register for those. To get the certificate of attendance, we do ask that you complete the surveys. And thank you to everybody who has already completed those surveys. I know that sometimes that initial demographic one is a lot, but it's a great way that we can then keep these ECHO sessions free of charge and show others that this is a valuable learning opportunity. But in order to get that credit for attendance, we do have to have you fill out the survey, and then we send you a certificate of attendance afterwards. Canvas and REDCap are our two programs that we use. REDCap is where the data collection, the survey is. So if there is any issues about getting that, check your spam or junk email folders. We usually email those surveys 1 to 2 days after the session, and then you get updates every week. Canvas is our site where we store PowerPoints, the recordings, and any other information. If you have struggles getting onto Canvas, please reach out to Project Scope or kurt.phillips@usu.edu. Kurt, I just saw your thing light up. Did you want to say something?
I was just going to say those surveys will come out, like Janelle says, 1 to 2 days after for that initial, and then it'll come out every Tuesday after that. So just look on, if you don't get it, look in your spam for on Tuesdays is when you'll get the reminder survey if you haven't filled it out already.
Okay, thank you. So today we were going to be talking about 2 topics. One was just celebrating healthy child development, and then implicit biases. One of the things that we are going to switch today is we are going to hold off on the healthy childhood development because we want to have enough time to talk about the implicit biases as well as our case presentation. So I'm really excited to have Heather from the Quality Improvement, the Utah Women and Newborn Quality Collaborative. She just brings a wealth of experience and information. The one thing I would just want to share is she loves Aggie ice cream. So if anybody has not tried Aggie ice cream, she'll tell you it's delicious. And us up here at USU would also say Aggie ice cream is the best. So I'm really excited to have her share with us. I'm going to stop sharing and let her take that over.
Great, thank you so much, Janelle. And yes, I do love Aggie ice cream. It's quite delicious. So if you have not, that's a good excuse to check out and go out to Logan. So welcome everyone. So excited to be here with you. And I'm excited to talk about implicit bias and what exactly it is and what we can do about it. So here's what we'll be covering today. I'm just really having a discussion about it. We'll be doing some breakout sessions and talking about some resources that are out there related to implicit bias. So what this session is not, it's not this magic wand, although I would love to be Harry Potter and have that magic wand. I'd actually like to be able to teleport to different places. That would be nice. It's not that, and it's not really telling you how to interact with your families. It looks like we have a really nice cross section here. We've got early intervention, we've got some nurses, midwives, physician's assistants, youth advocates, home visiting, school systems, and local health departments involved. So really excited to hear your perspectives on this particular topic. So a little bit about some implicit biases that I have experienced, a little bit about me. This is where I grew up in Yorkville, Indiana. It's about 40 miles west of Cincinnati. It's a very small town. And the house in the middle represents where we lived on 30 acres. There was probably, I would say the nearest neighbor was about a mile away. My dad, when I was a freshman in high school, at the end of that year, he took a job in Boca Raton, Florida. So we moved down to Florida, and along with that came a lot of biases that I had about moving to a larger city and biases that people had on me about moving from a rural area. It's definitely the tale of two cities and a very extreme culture shock for me. And I want to share, here's some of the other biases that I have experienced as well. So the top left-hand corner, that's my son. He was adopted from Guatemala, and you can see down here, he's got the nice dark skin. I am pretty white bread, do not have that. So I've experienced a lot of people that'll come up to me and they'll say, oh, are you his teacher? Or, you know, are you his caregiver? People that will assume because we look different that I'm not his mother. And so that is an implicit bias that people have. I'm also pretty tall. I'm about 5'11". So people assume because I'm tall that I can play basketball, which it is my favorite sport, but I am not a good basketball player. And so what I want to share is regardless of your height, you could be a really amazing basketball player or not. This is a picture here that has one of the tallest players ever in the NBA. He is, anybody know how tall he is? He used to play for the Houston Rockets.
7'4".
Close, 7'6". Yeah, 7'6", and he is here with Muggsy Bogues, who is the shortest person who played in the NBA. Any guesses on how tall he is? He was 5'3" in the NBA. So he played for 14 years in the NBA at 5'3". He is not the, let's see, the shortest person that ever dunked in the NBA was 5'7". So again, regardless of your height, you can do amazing things in basketball, unless you don't have the skill set like I do as far as hand-eye coordination. So I share these stories because we all come from different places, and that's the same whether you're working with early intervention clients, whether you're working with your community at the local health department, your clients as a midwife. Everyone's coming from a different place. And when we look at this picture here, people see different things, but really we all have the same goal of having those healthy outcomes for children and families. So we started an implicit bias project. We were able to get a grant from the Alliance for Innovation on Maternal Health, and we offered the e-learning course, Breaking Through Implicit Bias in Maternal Health Care. And if anyone's interested, feel free to send me an email. We do have a few users available for free of charge, and that's hsarin@utah.gov. I can put that in the chat as well. So we had them take this class, and then we did debrief sessions related to this and how it impacts care. What exactly is implicit bias? So this is the definition that is listed in the Quality Interactions and March of Dimes class. And it talks about actions, behaviors, and judgments that are influenced by stereotypes without our awareness or control. So does anybody know how many pieces of data can the human brain process in a second? Any guesses? I'll give you a hint, it's pretty big. It's actually 11 million pieces of data in a second, but most individuals, I know it seems like that, at least you know, with all the emails and everything else, right? But most individuals are only consciously aware of about 40 pieces of information at any given moment. And this is one of the reasons why we have all this stimuli and this over information. So we use these shortcuts to be able to understand and process that information. And that's one of the reasons that leads to this implicit biases. How about these? Have you guys heard of these? Any of these stereotypes? I think I've probably heard most of these. And I got called on it from one of my son's friends the other day because I assumed, you know, hey, he's Asian, he's good at math, and he's like, hey, that's a stereotype. And I was like, you're right. So there are a lot of stereotypes out there, and we just have to be aware of what they are and what we can do to address them. So why do we care, and why is this important? Well, there's a quote here from the Surgeon General in 2020, Jerome Adams, and he talks about asking you to help. He says, I ask you to help me fight stigma. I truly believe stigma is our biggest killer. Stigma kills more people than opioid overdoses. It keeps people from giving you help. And I'm sure that you guys have seen all of the data on the medical wise in terms of Black women, for example, are 60% more likely than white women to have a preterm birth. American Indians and Native and Black women are 2 to 3 times more likely to die of pregnancy complications. So a lot of these are really life and death because of these biases. There's education disparities on the type and quality. And then, as you all know, family experience really begins with that listening and really hearing from your families and what their needs are. So some ground rules, or really kind of a community agreement. These are ones that we've used in the past. You guys can take a look, and if anybody has any questions on these or ones that you'd like to add. I think we did add in session recently that having fun, so that should be a ground rule there. Okay, so you see implicit bias in various fields. You see it in the medical field, you see it in the education field, you see it in fields such as criminal justice. So I would love to hear either in the chat or unmute, what are some examples of implicit bias in early intervention? And again, because we have that broad range of folks, you could say what are examples of implicit bias, really just whatever field you're in. So if it's whether you're a nurse or in public health or any field, what are some of the things that you guys are currently seeing? Anyone willing to share anything that you're currently experiencing or have seen?
So somebody has put in that a mother is the primary caregiver. If you
That's
smoke, you are a bad parent. A delay in talking means autism.
Perfect.
People with dirty homes are bad parents.
Mm-hmm. Those are.
I know it's always hard to follow the chat, so I was trying to.
Thank you. No, I see this now. Perfect. I appreciate it. Yeah, the delay in talking. I remember we were at a friend's. My son was probably maybe 2, and he had like a chip in each hand, and their son was, having full conversations, and my son was like, more chips. So yeah. No, I think these are all helpful examples that you said that kids are, that are not clean parents or bad parents. There's a lot of social determinants of health that you mentioned in there. Low income homes are more likely to have children with delays, which again, I don't know the statistics off the top of my head, but my guess is that it's pretty across the board on demographics, similar to something as the violence. Domestic violence, for example, you see that across, or intimate partner violence across all demographics, regardless of income. Thank you for those. I so appreciate you sharing, and we will refer back to some of those as well. But this was from Parents Preventing Suspensions and Expulsions in Early Childhood Settings, and they talk about what exactly implicit bias is. Their notes say that it's race, ability, gender, culture, and language, and that these implicit biases can really affect how providers respond and perceive children. There's been a couple articles recently, and I'm glad to send out links if you're interested, on implicit bias specific to early intervention. So this first one here, the language we use, providers' perceptions about families. This one, they looked at some folks and they said, hey, usually the training on early intervention is very family centered. However, the language that we use is not. So some of these examples that you give actually are ones that they talk about in this study. So they talk about, parents' inability to be organized, and then relate that to the fact that they aren't capable of parenting. They have various examples of that. Pretty interesting study. This other one is confronting racism and bias with early intervention, the responsibility of systems and individuals to influence change and advance equity. And it talks about ways that you can be aware of it and ways that you can address it within your facilities, within your organizations. This was a blog that I saw that was quite interesting. It's by Becky Ferrigno in 2020. And you guys have probably heard most of these around early intervention. So I'll let you kind of take a look at these fears. And again, feel free to unmute or put in the chat if you have heard some of these fears and stigmas. One of her points in this article is that people are afraid to get services early because of some of these fears. So for example, the last one that she notes here, they'll always have a label, for example, is one that she said, you know, potentially holds people back. And fear number 2, if I were a better parent, my child wouldn't be having these problems. So I don't know if you guys have seen any of those at all.
Yeah, the other one I always see a lot, Heather, is if I just did more, then my child wouldn't be struggling with this.
Right.
So me who's not doing it.
Right. Exactly. Taking a lot of the blame. And yeah, feeling that burden on themselves. For sure. I try to tell myself I have a challenging teenager, so I try to tell myself that it's not that I'm not doing enough, it's just they're a teenager. So okay, so these are some of the implicit biases that we see in maternal and child health, specifically with pregnant persons. So we see, you guys had mentioned your income, so the poor. Some people are biased against if someone is overweight. We see that they, as far as receiving health care and receiving treatment, that again, there's biases there. In this context, we see women and families with substance use disorder, and we see a lot of biases around specific to that and specific to people not realizing that it's a chronic disease and people thinking that it's a moral failing. And so people have a challenging time understanding that it's not your moral fortitude. It is a chronic disease. And so I think that also impacts your health. And it also, in talking with women with lived experience, it also means that they may not be going for the care that they need. We mentioned the social determinants of health, so anything from the education to housing to transportation. I've talked to clinicians and they get very frustrated because a lot of this population is unable to show up for appointments. And rather than asking why they aren't able to attend, they just get very frustrated. But when you start digging into the root cause of that, it's because, well, they have to take 2 buses to get there. They don't have childcare, they're working 2 jobs, and it's very difficult to get to these appointments, for example. And that's just one example of some of the social determinants of health areas that these families could be facing. Anything else on any of these here? Okay, so there are many biases. It could be a same-sex couple as parents. It could be the mom is too old or the mom is too young. It could be the way that the mom looks. Some people have biases related to tattoos, for example. It could be that the parents have not finished schooling. There's a lot of different biases. So I think we just really need to take a step back and realize what biases are we having and what exactly can we do to address those biases. Okay, so some ideas on how to reduce implicit bias. Do you guys have any off the top of your head that you'd like to share? There are some helpful ones on the March of Dimes website that have how to be a change agent. So one of the first steps is really understanding and being aware of your prejudice, making your work a judgment-free zone. So in working with various hospitals, one of the nurses shared that she wants to make sure that whatever they say about a patient, that they could do it with the door open so they wouldn't be embarrassed if someone hears it. And then also just having these discussions, whether it's at a staff meeting or just amongst your peers really just talking about what you can do to address this issue. There's a Words Matter initiative out there, and it talks about stigmatizing language in red here and non-stigmatizing language. So really trying to encourage, and you guys are very aware, I'm sure, of the person first language, but really trying to move away from things on the left-hand side of this chart and moving to the right-hand side. There are some words on here. I didn't even know that the origin of the word junkie, for example. So in the 1920s, people started selling scrap or junk for their substance use to be able to pay for that. And so that's how the term junkie started. I did not know that. If you look at some of the non-stigmatizing language, we're working with people in recovery. We're working with substance-free or positive and negative as opposed to clean and dirty, and just really focusing and really making the person feel like they matter. There is a quote, looking for it here, but basically the gist of it is trying to make sure that everyone feels valued. And when you start putting some of these labels on folks, they don't feel valued and they don't feel like they can share any information. You will see, or at least historically, we've seen people in the media doing dun dun dun, addicted at birth, and have a huge story on that. This was one example here, and I'm very proud of the University of Utah. On their website, they have dependent, not addicted infants in the opioid epidemic, and they talk about how infants actually can't be addicted. It's that they're dependent. And so again, it goes back to using that language that is uplifting and supportive. In public health, it's always helpful to get a sense of what is the prevalence of this issue. So the chart here on the left talks about the rate of newborns with neonatal abstinence syndrome per 1,000 live births. So in the latest data that we have, 2020, it was 10.8 per 1,000 births. And if you look at some of the research that Dr. Marcella Smid has done, they did a statewide study recently on cords. So basically they worked and they got anonymous cords donated. So when mothers give birth, and they were able to work with, I want to say over 80% of the hospitals. And what they found was that 10% of women in the last trimester had some form of substance within their system. So if you extrapolate that, you can roughly say 10% of the population has substances or is in using substances, and they did not differentiate. That could be, you know, I'm taking opioids for chronic pain, or it could be that I'm using them illegally. Regardless of whatever the prevalence, whether you're looking at NAS or NOWS, or if you're looking specific to other areas that we see, this statistic to me really speaks to how important this issue is. So last year, unfortunately, we hit over 100,000 drug overdose deaths, which to me is just mind-blowing. If you take the amount of car crashes and the amount of suicides, like that doesn't even add up to this 100,000 last year. It's basically, these are categorized as unintentional injuries as of death. So it's the fourth leading cause of death behind heart disease, cancer, and COVID in 2021. So to me, that's showing that, again, it's a severe issue. It's something that we need to address. And I was at the dentist the other day and I said, do you guys have any naloxone? And they said, no, we don't have clients, that struggle with that. And I had to, not jump out of my chair and say, oh, I think you do. Look at the statistics. It's really concerning. And this is an issue that really everyone should be involved with, and really trying to figure out, like, how do we move from the punitive and more towards treatment and getting people into help. So this is one of the tools that they talked about in the study, in the class, sorry, with March of Dimes and Quality Interactions. They call it the ally model. And basically it's what you do with either your clients or your patients. So it's really avoiding assumptions by relying on objective information and evidence. And it's hard because I do this a lot. Someone cuts me off when I'm driving and I assume that they are a jerk. But it may just be that they're trying to get to somewhere fast. So I have to kind of step back, avoid those assumptions, and then learning about the whole parent by asking open-ended questions. And this is hard to do because we all have limited time. We have a to-do list and we're trying to get through as fast as we can, and really stopping and taking time to listen is very significant and really helps people feel more involved and more respected, and makes them more willing to share and get involved. And the next L is listening more than you talk, which again is very difficult as well, and yielding to the parent by involving them specifically in their care. So we can move now to our breakout sessions. I'd love for you to have this discussion with your colleagues. And here are some of the questions, and I think we'll put those over to the chat. They're going to divide us up into smaller groups, and here are some of the questions. Sharing examples of where you've seen implicit bias, what you can do to help reduce implicit bias, what are some barriers, what are ways that we can overcome, and what is one thing that you'll be implementing to reduce implicit bias?
Oh.
Yeah, I'll open the rooms now.
Okay, Bailey's
Perfect.
gonna put us into those. If you want to take she's put them in the chat. Heather's going to run one. Kurt is going to be the leader in one. I will, as well as Tiffany Warwood and Lisa Davenport. So if you just remember to take notes, and as we come back to have those discussions, but those are going to be the leads.
Okay, so everyone should see an invitation to join. Lisa, Brianna, and Mary, go ahead and join. We just went into breakout groups, so if you can, go ahead and join.
Thank you so much. Wonderful. Well, are a few people willing to share some of the themes or some of the things that you talked about within your groups?
So I'll start with it. Our group had some great ideas, and a couple of things that they really talked about was always including dads, doing different trainings, and thinking about just our own awareness. A couple of people talked about those pictures where you look at all the negative things and then you flip it around and look at all the positive. So really trying to take that perspective, those positives. And then someone also shared always looking at it from a family's perspective, which I just thought that those were some great ideas and suggestions. Kurt, how about your group?
Most of our group centered around just that self-reflection and having time to just think about it, because it's always easy to see bias in other people, but I think a lot of times it's hard to see bias in ourselves. I mean, I think about, you know, if you just look at, and I'm going just into politics, if you go to politics, if you're on the right side of the aisle, everybody on the left side of the aisle is a bad person. If you're on the left side of the aisle, everybody on the right side is a bad person. When 99% of that person's makeup is good, and you may disagree on one or two things, but the majority of what you would agree on, that's the majority of you know, your belief systems and that type of stuff. And so I think that, you know, it goes across all spectrums, not just race or socioeconomic status, but I mean, you think about religion and politics and even things like hair color and you know, who you hang out with at school and those kind of things. So I think it starts at a young age, and we just need to take that time to think on our own to see where our biases are. And had a comment that said, you know, it's important that we reflect on our own biases and see where they came from, what caused us to have those biases.
Thank you. Do we have any other groups that would like to share some key thoughts?
One of the things that was brought out in our group that I really liked was the fact that the need for training. One of the comments was that they weren't even completely certain what implicit bias meant until, you know, they had had this training and they had learned what it was. And I think that's huge, because sometimes we, you know, we just live our lives. We're doing the very best we can. We, you know, we go from day to day. And oftentimes it takes something like that to help us to realize what we could be changing, what we could be doing differently. So anyway, I like that comment. One of the other things that we talked about was how to overcome the barriers of, you know, just trying to approach coworkers in a way that is caring and understanding, to discuss the possible implicit biases that they might have. And that can be how difficult that can be, you know, because you work with these people every day, you learn to care for them in some way or another. You think you know their personalities, their, you know, their pieces of their personal lives. And so then having the gumption or having the, you know, the know-how to approach them and to discuss these things openly can be a really big challenge. So that was something that was brought up as well.
That's awesome. Heather, I'm just going to really
Thanks.
quickly share that Holly in the chat, she was in our
IAT
breakout group, and she put in that test that you can check your own implicit biases. So she put in the chat with that. I think that's a great thing to think about too. So
Definitely. They have a lot of different categories, and they're actually developing one for substance use disorder, but they do have a lot of different categories in there. And it is quite an interesting test to take. Great. Anybody else interested in sharing? Just a few highlights from some of the things that our group talked about. They talked about from the very beginning when they do the intake that there may be some biases, like this is a quote hard one, and trying to really be neutral on that. We talked about it within the school system and how students are labeled as one thing, and then it becomes a self-fulfilling prophecy because teachers will treat them per that. DCFS, we talked about that and some biases there and people not believing in people and how eventually that one worked out. And neighborhoods and areas, moms that are too young were some of the other discussions that we had around that. So I appreciate everyone's willingness to share, and I will just share, I know that we're wrapping up here in the last few minutes, but I will, we do have some resources that I am glad to share. And I'm so glad, thank you, Holly, for bringing up the IAT. We have it in here, and it's, like I said, very interesting to take. There's this implicit bias resource guide that's by the National Institute for Children's Health Quality, and has some really interesting examples in there. There are some very sad ones. So for example, patient of color was going in for was having an asthma attack, the child, and as soon as they went to the desk and the person that was intaking realized they were on Medicaid, she said, "Oh, you're going to have to wait for your doctor." And so, I mean, this poor girl almost died because she had to wait. There was that bias there. And then there was another one actually from Utah that talked about a woman who, she's in her 30s, she runs a nonprofit, and she was up at the Capitol during the legislative session and advocating. And she said constantly people would come up to her, whether it's staff or other people, and say, "Oh, you need to stay with your students," or you need, you know, they were assuming that she was a chaperone, whereas they would not do that with any of her male colleagues. So some interesting biases in there and some great things. We talked about the change agent, and then there's some links here. And I don't know if any of you watched the movie Zootopia at all, but I can also send out a clip from there that is quite interesting. So I want to wrap up here, just kind of some of the next steps. I think hopefully this just opens your eyes to kind of just start talking about implicit bias. And I love what someone brought up about just that need for training and just being able to be caring and understanding towards your coworkers and family and friends related to this. And I just challenge each of you to really implement like one thing that you decide to reduce implicit bias. And I think that all of us can just pick, you know, what it can be very simple thing to do to help address that. And I think really just education, educating yourself and others. And as I said, I'm glad to share the resources. And I think this is kind of a workout for your brain. I was reading an interesting statistic this morning. So the United States has more gyms than it has McDonald's, Dunkin' Donuts, and Taco Bell's combined. Any guesses on how many gyms we have? 32,270 gyms in the United States. This is according to this article in April. So like a gym, like you have to always make an effort to go to the gym. And I think with this, you always have to make an effort to think about it and to address it. So I just encourage you to do that and really implement the one thing. And I'm glad to serve as a resource. And I will now turn the time over to our next speaker, Caroline.
And so, Heather, one of the things I just also had to catch myself right there, I just had my own implicit bias because I thought we have more gyms because aren't we one of the most overweight nations too? So remembering to think about that.
I was quite surprised by that statistic, yes.
Oh, well, thank you so much for sharing. All this information will be on our Canvas site. I'm gonna find Carolyn on my screen and let her, there you are. So we are going to have her share our case presentation, and then we will go into breakout rooms again to find out some great resources for her. So Carolyn.
Perfect. It's really nice to be with you guys today, and thanks for allowing me to share a case with everyone. Can everyone see my screen okay? Okay, perfect. And we're actually going to, sorry, I just want to make sure I can have my notes right here.
Oh, now you're muted. Sorry, Caroline.
Yep, that's okay.
There you go.
You didn't make me have to talk too much about that, right? So the background on this case. So first of all, my name is Caroline Flora. I work with Weaver Morgan Early Intervention, and I am a developmental specialist. And the background on this case is he is a 21-month-old. Mom and dad are white, non-Hispanic, living in northern Utah. Mom has used opioids and meth during her pregnancy since she was 14. The child was medicated with morphine in the NICU for 8 days to withdraw. And now mom is currently pregnant with a second child. Mom has separated from dad until he finishes his treatment. The family history, we have a lot of family history with autism, ADHD, depression, anxiety, and bipolar. So our primary area of concern with this child is, first of all, is our communication. As many of you guys know, in early intervention at 21 months old, we should be seeing a little bit closer to, between 15 to 50 words. And right now he's only speaking about 8 words. He has momentary eye contact. Mom describes him as too busy to listen. And he rarely will follow one-step directions. So along with communication has one area of concern, and the second main concern is the negative behavior that this little boy has. Some of the negative behavior that this little boy goes through is he has really long-lasting and intense tantrums and behaviors. Some of these intense tantrums include head banging, biting. Again, he doesn't really understand when to feel sorry for children or for parents. He does things like hits mom's pregnant tummy and thinks it's funny. And some of these tantrums will go 30 to 45 minutes long, and they happen frequently, especially when mom wants to intervene. Another behavior that we are working on is decreasing screen time and allowing mom to understand the statistics with decreasing screen time and the correlation with children and how much time a child should have screen time. Since in today's world, it's really hard to find parents who, screens are just a part of our days right now, but how much is too much? And so just educating mom on screen time and trying to decrease that as much as possible. In early intervention, we have a lot of goals for this child. The first one is to progress his language development. Right now, he has about 8 words. And so we're hoping he's coming up on his 2nd birthday. We're hoping that when he hits his 2nd birthday, we can go from 8 words to hopefully 20 functional words that he's able to communicate appropriately to his mom, instead of these tantrums and crying and screaming and throwing himself to the ground because there's just this communication barrier where he's not getting his needs and his wants met by his mom. Another really important goal that we have for this child is identifying the cause of the negative behaviors. For mom, it's been a lot of parent education on, is he having these negative behaviors to self-soothe? Is he having these negative behaviors because he needs more one-on-one time with mom? Is he having these negative behaviors because dad is now out of the picture? So we're really trying to identify what's causing these negative behaviors, because then it's going to help us navigate how we can help him. And the most important part about this goal is we really want mom to feel comfortable using healthy skills and strategies, and for her to be comfortable with these. So that goal that we have in early intervention is not just for this little boy, but it's also for mom to feel comfortable doing. And so we really want her to feel very confident. And some of the barriers that we've seen with this child and with mom that I would love to hear from you guys on, maybe what would be the next step or what you would do to help this family and this child, is mom's having a really hard time scheduling in-home visits, and she cancels frequently. And it's really hard to, fulfill these goals and get this child not only on track with his learning development, but also making sure that mom's okay. Mom has this 2nd pregnancy coming up. She has just finished treatment. She actually finished treatment right when she found out that she was pregnant. So there hasn't been a lot of time for sobriety. And so we really want to make sure that we're giving mom as much support that we can. Mom has and tends to speak like this very often. She has the self-fulfilling prophecy thinking. She's expressed to me and our eligibility team that she's always been a drug user. How do I stop? My family's had addiction. How do I stop? Can I stop? A lot of doubt right now, and giving mom that confidence to feel like you can do this, and validating that this is hard. I think that's been one barrier that we've worked on. Is sometimes it's really easy for providers for us to say, no, you can do it. You know, I have faith in you. You can do it. You know, I believe in you. When sometimes we've really I've tried to empathize with her and say, I know this is hard. How can we help? Just to validate her feeling and what she's going through. The other barrier that we've seen with this child is he does not like to be told no. When he's told no, usually it's no to screen times. Sometimes it's no, you know, we're not going to headbang. We're not going to bite mom. We're not going to hit mom's tummy. He turns to a lot of self-harming or harming others. And mom has felt this defeat feeling where if she says no, he's going to hurt himself. And how do I stop this? He's getting bigger. He's getting stronger. Right now, I'm trying to protect myself because I'm carrying this child. When sometimes letting him be in the corner, giving him the screen time, being by himself has been the best thing for her, especially as she's dealing with a lot of the stress of being a single parent, being pregnant, working full time, and having a DCFS case open, working with a therapist, and working with a case manager. There's a lot on this mama's plate right now. So we've had, with this child, we've actually just started services. We've only had 2 successful visits because mom is having a hard time keeping her visits. Sometimes she will say, let's just do a virtual visit. Things are really hard, and then cancel last minute. And so in our few visits, we have been able to give a lot of tools and strategies for her. The first strategy that we've given is the idea of love and logic. And for anyone who's unfamiliar with love and logic, you know, just a quick description of it is, you know, letting children understand why the consequences are coming, understanding that where the consequences are coming from an act of love. And so definitely I would, if you're unfamiliar with love and logic, definitely take a look at that. That's a really great way that I've been able to express to mom, how do we communicate with this little boy and be able to give him love and also make sure that he is not getting away with these negative actions and behaviors, and knowing that if he fights hard enough, he'll just be able to escape the situation. The next suggestion that we've used during visits, I actually want to just ping on the love and logic one more time. Mom has expressed that she loves this idea and loves, you know, identifying feelings and identifying that he's having a hard time and giving that logic parenting back to him. But she feels exhausted when she's working full time, you know, she's pregnant. And so she has expressed that this has been hard to follow through with. And sometimes it's just easy to yell or tell him no or take him out of the situation. The next suggestion is planned ignoring. And, you know, planned ignoring is the idea that for how much attention we give to something, that will increase. And so it's a little bit like the opposite of love and logic. Planned ignoring needs to be done a little bit carefully because we don't want to ignore harmful behaviors like he's been showing us, like headbanging, biting, hurting others. But we can use planned ignoring when he's having a tantrum or he's holding on to mom and telling her to stay when she wants to go up the stairs. Letting him know that if he wants that love and that attention and those hugs and those kisses that he really is desiring, he needs to show those appropriate ways of asking, or just not in a violent or aggressive way. Again, like you mentioned before, it's really important that we identify why he's attention seeking. You know, maybe it's because mom's starting to work full time. Maybe it's because dad is no longer in the picture until he finishes treatment. There's a lot of change that's been going on. This child, a little bit of back history, she was living in a foster care family's home up until about 6 months ago. So mom has just regained custody. So this child has seen a lot of different parent strategies, a lot of different parent styles, and I've seen a lot of different adults trying to help with his behavior and with his attention and with his communication. Most of you might be familiar with time ins and not time outs. That's one area that we've really tried to suggest with mom, again, to give that loving time with him when he is having those really hard meltdowns, to be in tune with him, to sit with him during these really excessive tantrums and aggression feelings where he's not alone, but we're not giving him necessarily the attention that if he's seeking. So we want to be in tune with how he's feeling and validating what he's feeling. And again, decreasing screen time has been a priority for the family, and mom reports that it has helped a little bit, but once a child is used to so much time on the screen, it's really hard to decrease that and to take that away once they're used to so much screen time. Another suggestion that we've used is a lot of heavy work activities. Since this child has shown so much aggression and a lot of hyperactivity, heavy work activities can be a healthy input, especially for sensory, for this child to get this energy out. And some of the heavy work activities that we've used is, you know, bouncing on the trampoline, dancing. If we're going to use screen time, let's put on something that he wants to dance to. If we really want to get creative, he loves his little backpack. Let's put really heavy toys into the backpack and have him carry around that backpack so he's tired out. So we're really trying to imply those heavy work activities. And lastly, just with his communication, we know that there is an overlap of why he's behaving the way that he is, because there is a communication barrier right now. And we know that if he can communicate, especially communicate in a healthy way, these behaviors and aggression should taper down a little bit. So some of the techniques that we've used is narrative talking, talking about what he's doing, you know, being in that third person, talking about what you are doing, just really talking to him. You know, he has had so much time away from mom right now where we've just tried to, how do we get that bond back with mom? There's been so much time where he hasn't been with mom. And so hopefully, you know, talking with him through stories or just talking in his daily routines will help, along with expansion, playful sabotage, and increased wait time. So all suggestions that we've been using during our few visits. And it seems like a lot, but we've been trying to give as many strategies out to mom, especially with how much she's been canceling lately. So with our community discussion, there are a lot of things that we can discuss about this child, about his learning delays, and kind of diving into our implicit biases. Now that we know the background of this child and how it correlates to implicit biases, you know, we as a community, do we believe that his learning delays are merely the consequences of NAS? Do other people in the community feel that way? Is that just something that a child experiences because he had so much drug exposure? And as providers, we're a little bit more educated, but what biases do the community have regarding NAS children and their development? And do you feel like the community really is rooting for these children and these families? You know, I have heard that sometimes families or moms that are having a DCFS case open, they feel like these community providers maybe aren't necessarily on their team? Are they really rooting for them to have their child come back and be in a stable home? And so I just kind of want to talk a little bit about that as our first question is, what have you seen in your community, good and bad? And do you feel like these delays are the consequences of NAS, or do you feel like there's more to the story?
Awesome. Okay, so does anyone have any questions really quick before we go into breakout rooms for Caroline? Like any clarification questions? Okay. I think, okay, then we will go ahead and break out into our groups. Just remember these questions, and then if someone can make sure to take notes. I have Tiffany, Kurt, and Lisa as our group leaders. So if you can make sure someone takes notes. We'll be in the groups for about 10 minutes. And then we'll come back, and depending on time, we may or may not share, but Caroline will definitely make sure you get a copy of all the suggestions. So go ahead and join your groups. Paige and Lisa, did you guys see a thing pop up to join the group?
Yes, I did. This is Lisa, and I'm going to join right now. Sorry, a little technical difficulty.
Nope, you're okay. I just want to make sure, because sometimes it doesn't send to people. So
No, that's okay. I appreciate you asking. The questions, is there a link? Because I didn't get a picture of the questions that we're supposed to be talking about.
yes, I can. I'll broadcast them into the chat for everyone.
Perfect. Thank you.
You're welcome. Yeah. Yes. Welcome back, everyone. I think just checking, we have everyone. I hope your guys' groups went well. Janelle had to hop off to join another meeting, so that's why you get me. But we're gonna go ahead and just wrap up. We don't have time to share, but hub members and people who like, you can make sure you email whoever you're supposed to email. I think it's Janelle. Kurt, do you know? Janelle? Okay. Yeah, email Janelle with your notes. That way we can get them to Caroline, and they will be posted on Canvas so everyone else can go look to see what other groups talked about. And then make sure you register for our next session, which is on the 25th, and it's going to be out about trauma and the ARC framework. And it should be really good. And then Kurt, you have anything else to add?
Nope, just be looking for a survey between now and Friday, and then it should kick another one through every Tuesday. I'm learning that I try to set it at 10 o'clock on Tuesday, but I think it goes by what the median time in England. So it probably shows up about 4 o'clock in the morning. I apologize. Just turn your phone off at night.
Awesome.
Thanks.
Okay. So thanks everyone for joining. Have a great rest of your day. Bye.
Thank you.
Bye. Thank you.
Thank you.